Good morning, everybody. I think we can go ahead and start. Thank you for joining us this morning in a very exciting breakout session. We'll welcome everybody to stay, and of people may trickle in as we have many excellent breakout sessions this morning. We had this great problem in the organizing committee. We had many great ideas, right, Silpa? So it was hard to accommodate everything, but we had these concurrent sessions. So today, we're going to talk about immunotherapy, immunology, and the intersections of the two, and the applications of this understanding and concept in bladder cancer. And of course, we think about biology, we think about immunology and the lab and the science, and we think about also therapeutic applications to patients. So we're going to have a session which is multifaceted, and we're going to have excellent representations from different disciplines. And we also thought that it would be great to learn not only from bladder cancer-minded folks, but for leaders in the field, international leaders like Selender and Brian, who are leading the field in terms of immunotherapy in cutaneous malignancies and kidney cancer, respectively. So we're going to have a lot of discussions. We're going to make this session interactive. On behalf of my dear friend and colleague, Dr. Neelam Mukherjee, and myself, I'm Petros Grivas. I'm at the University of Washington Fairfax Cancer Center. We're very excited for this program. As you can see, I'm sitting among really brilliant people here. So very briefly, I will introduce them, and then I will ask Neelam to take over. So Neelam Mukherjee is an assistant professor in the UT Health Center in San Antonio, in Texas. And I'm sure she loves to be here. The weather's probably less hot and humid. Next to Neelam, who is a co-chair of this session. And by the way, Neelam, we did a similar session last year. It was such a big success that I think we're kind of back due to popular demand, sort of speaking, and thanks to your efforts. Next to Neelam, we have Dr. Madhuri Koti. Madhuri, another brilliant scientist. She's coming from Canada, and Madhuri is in the Sinclair Cancer Institute, associate professor there, doing great work in immunology. Next to Madhuri, and next to me, is another dear friend and colleague, Dr. Silpa Gupta, who is a professor, recently promoted. Silpa, congratulations at the Cleveland Clinic. Yeah. Well deserved, and she's going to give us the context of bladder cancer immunotherapy, great work in the field and contribution. On my left, we have like this setup of the ladies and the gentlemen here today, randomly sitting. So my dear friend and colleague from UW and Fred Hutchinson Cancer Center, Dr. Selender Bhatia, who is a professor of oncology in UW and Fred Hutchinson, leading the field in cutaneous malignancies with plenty of experience in immunotherapy. And last but not least, a dear friend, colleague, and amazing person who I worked with for 4 years at Cleveland Clinic. Had the offices next to each other, learned a lot from him. Dr. Brian Rini, you probably know him already. He's a leader in the field, international known in kidney cancer, professor at Vanderbilt Cancer Institute, and also he's leading the clinical trial office there. So thanks everybody for joining.
This was a kidney cancer meeting, is it not?
We're going to make it sort of. So, we had an idea with Brian. As you probably already know, Brian and Tom Pauls are the two very famous Euromigos. They have a tremendous podcast, one of the most popular podcasts, I would say, in oncology and urology. And we had the Euromigos meeting in Nashville every September. We're going to have the third meeting this coming September 27, 28. And they had this amazing idea of the Euromigos Cup, which is kind of a medical knowledge competition. And we had the idea of bringing the cup here so people can see it, but it was too heavy to carry.
It's like the Stanley Cup.
It's like the Stanley Cup. I'll ship it from Seattle to Nashville in a few days. So thanks again, everybody, for joining. Neelam, you take over, my friend. Thank you.
Yeah, thank you, Dr. Grivas. Petros, he has always been very helpful in organizing the last year's sessions as well as this year's session. 2 years back, Tyler complained that we don't have pure immunology sessions, so this was the reason that kind of said that we'll have a pure immunology session and not just for clinicians, but also the basic science researcher here and form a dialogue between them. So that was the foundation of why the last year's sessions as well as this year's sessions was built. So Petros already mentioned the format. I think we'll start with Dr. Shilpa. And she will give an overview of the immune therapy landscape. And then we will go into my and Dr. Kote's talks and finish off with the lessons from other cancers. So, yeah.
I think the fantastic AV team already have your slides, yes. Dr. Gupta, so we're good to go. Thank you.
Thank you, Petros and Neelam, for the opportunity to talk about, to be part of this exciting session. So I'll talk about the current landscape and challenges of immune therapy in bladder cancer. The group already knows, so there's not a lot to tell, so we'll quickly go through this and leave a lot of room for discussion. These are my disclosures. So as you all know, for the long time of over 40 years, we did not have any therapeutic advances until the advent of immunotherapy back in 2017. The first immunotherapy to be approved post-platinum setting was atezolizumab. Then we have 4 more immunotherapies which were approved back-to-back within a year. We got the first targeted therapy, or erdafitinib, approved for FGFR-altered tumors for patients in 2018. And 2019, sorry, and the first antibody drug conjugate, enfortumab vedotin, was also approved that year. We then had the approval of avelumab immunotherapy in the maintenance setting, which was the first time we'd seen immunotherapy move a bit earlier than refractory setting. And another antibody drug conjugate, sacituzumab govitecan, which received the accelerated approval post-IO, post-platinum. And EV received the full FDA approval based on the positive phase 3 trial back in 2021. And EV Pembro, which we hear about a lot from everybody, including urologists who don't even treat the patients, is something which has gained a lot of momentum. It was first approved in frontline cisplatin-ineligible patients in the US in 2023, and now it got the full approval for all comers in the frontline setting. We also got approval of Gemcis and nivolumab for cisplatin-eligible patients this year. So a lot of advancements. And if we date back to pre-ESMO of last year, this used to be our landscape for, or at least a guiding platform for treating patients. If somebody could get platinums, we were offering them platinum chemotherapy, Gemcis or Gem-carbo, and if they did not progress, they would get avelumab maintenance. If they progressed, they would get pembrolizumab or any other immunotherapy that people wanted to use, but pembrolizumab is the only one with level 1 evidence. Erdafitinib if they had tumors harboring FGFR2/3 alterations. And then if they progressed, they could get whatever they had not had before, like EV or sacituzumab, etc. For truly platinum-ineligible patients, pembrolizumab was the standard of care, and erdafitinib in select cases, and also EV in select patients, because sometimes these patients are very frail and you don't want to use EV, that's why I said select. And we've also learned over the years that frontline combination of platinum and immunotherapy did not improve overall survival until recent data from Checkmate 901 compared to chemotherapy alone. And frontline immunotherapy was also not better than Gem-carbo for cisplatin-ineligible patients. We also learned that switch maintenance immunotherapy after frontline platinum was a very effective approach. This was based on the Javelin Bladder 100 trial, where patients who did not progress after platinums were randomized to avelumab or best supportive care. We saw that there was a significant improvement in overall survival as well as progression-free survival. And now let's talk about the frontline EV Pembro, which received a standing ovation at ESMO when Dr. Pauls presented the data. These were treatment-naive patients who were eligible to receive platinums. That's why the minimum creatinine clearance was 30 mils per minute. They were randomized to EV Pembro or Gemcis or Gem-carbo. The chemotherapy was up to 6 cycles. EV Pembro was, the Pembro was a maximum of 2 years, and there was no end date for EV. And we'll discuss the nuances later. Dual primary endpoints were PFS and OS. As we all know, the PFS was doubled, hazard ratio 0.45. OS was also doubled with a hazard ratio of 0.47, really not seen such data before. This was consistent across eligibility for cisplatin, across PD-L1 expression. You can see the efficacy is really pretty clear here. And also the more important thing is that in patients with visceral metastases, this was really a very effective therapy. So no matter where the site of metastases, EV Pembro was the clear winner. The confirmed overall response rates with EV Pembro are close to 68% versus 44% with chemo and 29% complete. This was complete responses in 29% patients. The toxicities here, numerically, it appears that EV-Pembro has lower grade 3 or higher events compared to chemo, but we just have to be aware that the toxicities are very different. While with chemo, we see mainly myelosuppression, which we are all used to, even preventing. We see neuropathy with cisplatin. With EV-Pembro, the main toxicities are peripheral neuropathy, rash, fatigue, and it really involves a lot of good physical exam every time to make sure we're not treating patients through these bad side effects, because those get better when we do treatment dose adjustments. We also saw the quality of life data at ASCO this year, where EV-Pembro did not cause a detriment in patients' pain or quality of life, especially in patients with baseline moderate to severe pain. EV-Pembro was clearly superior compared to chemotherapy, and this was really important work because patients continued to fill quality of life surveys even when they progressed on the treatment, which is usually not the case. So this really captured the patients' voices throughout their journey. We'll also talk about the frontline GemCis-Nivo data in frontline setting, which is the first time chemoimmunotherapy has shown efficacy. This was obviously for patients eligible for cisplatin, randomized to GemCis and GemCis-Nivo chemotherapy cycles for up to 6 cycles, and nivolumab continued as maintenance for up to 2 years. The overall survival was improved numerically, and we don't want to compare to EV-Pembro, but we will for the sake of, like we always do, and you can see that the results are not as dramatic, and that's why we don't know if the immunotherapy is acting more in the maintenance setting or does it really act in the combination. The PFS numerically was really not that different, but the durability was quite impressive. Response rates were higher than GemCis alone, 57% versus 43%. Want to highlight here that in both EV-302 and CheckMate 901, the control arm, not everyone got maintenance avelumab, but it was still around 30% in the EV-302 trial, and it was less than 20% in this trial. So that's one of the caveats here. Toxicities were mostly as expected from chemo and immunotherapy. And so that is the frontline scenario right now. Talking about novel therapies, EV is one of the most effective agents we have today. It's a novel antibody targeting Nectin-4. And won't go into the mechanism too much. Payload is MMAE. We saw higher responses with EV compared to chemo, 41% versus 18%. And this was for patients who'd had prior platinums and prior immunotherapy. So in the current scenario, at least in the US, this may be a moot point unless patients did not get EV-Pembro in the frontline setting. Sacituzumab govitecan is another antibody-drug conjugate targeting TROP2. It did show promising activity in a single-arm trial, but unfortunately, the phase 3 trial, we read in the press release that it was not superior to salvage chemotherapy, and not only that, it did cause more deaths, and there were more side effects. So we're waiting to hear the full data and as to where this agent will remain, whether it will still remain as an option in the US or not, because right now it only has an accelerated approval. This is the third ADC, which is also available for urothelial cancer patients based on the tumor agnostic trial, Destiny Pan Tumor 02. This targets HER2. And as you can see here, median progression-free survival in the bladder cohort was pretty impressive for both HER2 positive and HER3 positive. But even in HER2 positive, it showed efficacy. So if patients don't have any other options, one could consider this. Erdafitinib is the FGFR inhibitor. This was the phase 3 TOR trial where they asked a number of questions. One was whether it is superior to salvage chemotherapy in patients with FGFR3 alterations. The other one was whether it should be used before or after pembrolizumab for patients with those mutations. So we saw that this was better than chemotherapy in this phase 3 trial. It has the full approval now. And also the other cohort showed that using pembrolizumab first is better than using erdafitinib first. So in the current available options, I would say the treatment paradigm would be that for any frontline treatment, EV-Pembro is the preferred option unless the patient has really uncontrolled diabetes, which will take a long time to control, or if they have really bad LFTs. But for the most part, there's not many contraindications to using EV-Pembro unless they have really severe neuropathy where you would not use it. And if patients progress and have targeted therapy option available, we use that. Platinums were used in the second line setting in the EV-302 after EV-Pembro in about 30% patients and did show efficacy. So I think that remains a viable option, and Gem-Carbo would be totally okay. We don't need to push for cisplatin because patients would have a lot of neuropathy from the EV-Pembro. And sacituzumab, again, a question we'll find out later what will happen to its future. The other alternative regimens are platinums followed by avelumab or Gemcis nivolumab, whatever one can use or one has access to in the rest of the world as well. And then EV as single agent will be an option. And for the truly platinum ineligible or EV-Pembro ineligible patients, single agent pembrolizumab is an option. Switching gears to earlier settings, in the adjuvant setting, we have seen infiltration of immunotherapy with 2 positive trials, CheckMate 274 with adjuvant nivolumab, which met the disease-free survival endpoint. OS has not been shown to be significant so far. Ambassador, which showed adjuvant pembrolizumab had a disease-free survival significantly improved. In the CheckMate 274, nivolumab was better than placebo in all comers, and the benefit was more pronounced in patients whose tumors express PD-L1. In Europe, it is only approved for patients whose tumors express PD-L1, unlike the US. This is from the Ambassador study, did not see any overall survival benefit, but there's disease-free survival benefit. There are a couple of ctDNA-guided adjuvant immunotherapy trials. This is, I think, as close to having a good biomarker in bladder cancer that we have right now. IMvigor011, which is randomizing patients with who have ctDNA conversion to positive to atezolizumab versus placebo, and this trial will finish accrual this year. And the other trial which recently got activated is Dr. Galsky's modern trial, which is asking a couple of questions about what to do if ctDNA is negative, then is there, do we really need to treat with immunotherapy, or we can do surveillance, and if they are ctDNA positive, can be further amplify with the addition of LAG-3 inhibitor. There's a lot of immunotherapy-based trials in the perioperative setting as well. This is for cisplatin-eligible patients, pretty much similar patient population and different IO partners. Out of all these, we have heard that the Niagara trial was positive for both overall survival and disease-free survival at the first analysis, which is really very impressive. And hopefully we will see this data at ESMO in September. And this was Gemcis plus minus durvalumab. In cisplatin ineligible patients, again, there's the Keynote 905, Pembro EV versus Pembro alone versus radical cystectomy. Then there's the Volga trial with durvalumab and Tremi plus minus EV, and the Sunrise 4 trial with TAR-200. So all these are really exciting trials. I know the Keynote 905 has recently completed accrual, so hopefully we'll start seeing the data next year. And moving further early on in the NMIBC setting, this is really a treatment space which has exploded in the recent couple of years with a variety of intravesical agents. Pembrolizumab is the only systemic therapy approved for BCG unresponsive patients, although the activity is modest at 19% at 12 months, but that is an option. But there's a lot of other approved therapies like the IL-15 superagonist, the FGFR inhibition via the TAR-210 intravesical device, and then there's the TAR-200 where the intravesical gemcitabine has shown really great data. So we'll find out in the coming years, and then there's the nadofaragine and also a lot of exciting agents. So immunotherapy has really become a part of all stages of bladder cancer, and as medical oncologists, we never treated patients with NMIBC before, and we are now in that space managing patients with our urologists. But it brings to the next question of what are the challenges and gaps? You know, there are still a lot of issues we don't know about immunotherapy. We offer it to everybody, but we know it's only effective in about 20% patients after platinums. But we have no biomarkers to decide which patient may benefit from it. PD-L1 has really panned out to be a useless biomarker in bladder cancer. We don't use it for treatment planning. And I think the way we have biomarkers in lung cancer and other cancers, we've really lagged behind in bladder cancer so far. TMB did emerge as a useful marker, but it has never been tested in prospective trials, so we really don't know how we can use that for decision making. We also have a lot of adverse events from immunotherapy, as all of you are aware, and also from the antibody drug conjugates, which we have no way to predict who will get those or not. They can happen anytime. They can be very severe, and if we are not cautious, it can result in serious outcomes. And we don't have any biomarkers for that currently, although work is ongoing. And I think we are likely over-treating patients with these treatments, and we need to talk about de-escalating trials. For example, in the EV302, we don't really need unlimited or never-ending use of EV. Median number of cycles was 9. So I think we need to think about backing off these therapies and trying to design those trials. In kidney cancer, and I'm sure Dr. Rini will talk about this, we have seen that immunotherapy after immunotherapy doesn't really work. In bladder cancer, we don't know that yet. We need to start thinking of if a patient got pembrolizumab in an NMIBC setting, and a couple of years later, if they become metastatic, would we want to re-challenge with immunotherapy or not? I think those are big questions. And last but not the least, I think even within the US, despite having these plethora of options, only 50% patients make it to second-line therapy for whatever reason. So if we think about the global picture, there's really big access issues, affordability issues, and we need to do more patient and provider education so they can manage the side effects for these novel therapies, because we are learning as these new drugs come along. That is my last slide. Thank you for your attention.
So we have a few minutes for questions if anybody would like to ask.
Yeah, we can probably, since we have many presentations, we can kind of break down the questions so if people can go to the microphone or speak loud. I have one for Silpa, actually, great presentation, Silpa, and you outlined the landscape so well, and you outlined the questions. Going back to this point of IO after IO, and we can definitely ask, Selena and Brian as well, what are your thoughts? I know we need trials in that setting, that question in urothelial carcinoma. We have seen data in kidney cancer. How do you approach that? And how can maybe Neelam and Madhuri can comment, how can we translate what we know about the occupancy receptor, right, from PD-1, PD-L1, and how long it stays in the system? You can comment too. How does this impact your decision-making, Silpa?
I think right now we're not seeing that as a big problem because immunotherapy is not approved in MIBC. Very few patients get pembro in NMIBC. But if I were to make a random guess, if they've had IO within 12 months, I would really not re-challenge, but would wait for prospective trials. Like if, let's say, somebody got pembro for NMIBC, and a year later they have metastatic disease, and we've seen such patients. Depends if they progressed while on pembro, I would not use EV pembro. I would just use platinums. If it's been a couple of years, then I would use EV pembro. But we need trials like the kidney cancer ones.
Got you. So the timing post, does it matter if someone progresses on versus later, in your opinion, or the toxicity?
Yeah, absolutely. I think if someone is progressing while on IO, I would not want to give IO. Or we see a lot of patients where they're switching from avelumab to pembrolizumab to nivolumab, and then EV pembro. So I think that needs to really be addressed, that we don't need to do that.
Selena, you want to comment? Or Brian?
I was just going to say, I'll talk about this a little bit, but I guess my question is, Do you really need to do the trials and repeat the experiment? Like we've done that in kidney cancer. Is there a reason to believe sequential IO would work in bladder when it hasn't worked anywhere else to my knowledge? Or just save yourself the hassle and do other things? You know what I mean?
That's a great point.
I don't know. I mean, and in kidney cancer, now that we have adjuvant pembro, the same thing. People say, oh, if it's been 6 months or 12 months, but we don't really know, right? I mean, there's no evidence. And from Tenevo 2, which I won't talk about, had about, I think, 15% of patients who had adjuvant pembro, right? We know from the press release, not the data yet, that it was negative. So, and I can't imagine that subgroup is going to be wildly positive. So I don't know. It's just sort of asking the question of all the resources, where do you put them to study this, or do you just assume that it's not active?
I want to hear Silpa, what you think too, but it's a great question, Brian. It's always about allocation of resources. We actually have a trial that it's about to launch, and hopefully we'll launch it. It's sacituzumab plus pembro versus Saci alone in the ECOG ACRIN 8231, has a number from the cooperative groups. Yeah. Phase 3 trial, trying to answer these questions definitively in urothelial carcinoma. The thought was that we didn't have the data there. This was before the Tenevo 2 came about, obviously, the press release. But we still felt that it would be nice to have that question answered in urothelial cancer because of the lack of specific cancer type data. This trial mandates prior immunotherapy and, of course, allows prior EV or platinum, so we have a lot of points of entry, adjuvant Evo or EV Pembro or Pembro alone kind of scenario. So we'll try to answer it in that setting.
Petros, I think that trial is very important. Congratulations. But it won't really answer the question of IO after IO. You're asking whether adding to sacituzumab is better than just sacituzumab. But we don't know if sacituzumab will remain in this space or not. So would love to see if this trial moves forward. Hopefully it does.
And that's a great point, Silpa, and that's where hopefully we can move it forward. Right now, there is an accelerated approval of SATSI. If that remains, I think at least scientifically will answer the question of the IORI challenge, since the control arm will be SATSI. I think we have a few questions. I think Ali, and then we can go to Fed and alternate.
Hi, Ali Kaki from Stanford. Thank you, great discussion. I'll just make a comment about the discussion, then I have a question. So, I mean, I think that the interesting thing, to Brian's point, is that is antibody-drug conjugates. Maybe there's a different reason to think there might be synergy there than with TKIs. So I think that the question of SG versus SGIO versus SG is an interesting question to hopefully answer that question. And maybe the antibody-drug conjugate will have some synergy in a way that prior TKIs have not had it in RCC, for example. So I think that'll be an interesting study that hopefully we'll get some more data from that. But my question is sort of to Shilpa about de-escalation and also about consolidative local therapy. So would be interested to know how you think about what do we need to do for de-escalation trials for bladder cancer, and then similarly for people who have an excellent response to EV Pembro, for example, get that 30% CR rate. Should we be consolidating them with some sort of local therapy to maybe convert these people from incurable to curable disease?
Yeah, that's a great point. In my current practice, if somebody has a CR or near CR, which is well maintained, I do give them treatment breaks or at least drop the EV, continue Pembro, and we've seen that we've not had to restart EV for a lot of our patients, and when we do, it works. For the de-escalation trials, I think because EV is like a chemotherapy, so I don't think we need unlimited treatment numbers. So if you do 6 cycles of combination and then just do Pembro maintenance, we're actually writing an IIT to do at our institution called Optimize, where we'll compare to the historic control of EV Pembro, but we'll do intermittent approach, like start with EV Pembro, stop it, things similar to what Brian had at the clinic with the Ipi-Nivo trial in RCC, so something like that, and we'll hope to get some answers. And consolidative therapy, I think, is a great question. I know some trials are ongoing in this space, but it depends where the Mets were, right? If it was locally advanced versus distant Mets, I think would make a difference. But if somebody had a CR in the liver, I don't know if removing their bladder necessary is needed. I mean, why go through that? They don't need to.
And Silpa, just to clarify, your design is single arm EV Pembro, and then you drop EV, or you do it intermittently like Brian's trial?
Yeah, you drop the EV, continue Pembro, and add EV if needed. Gotcha. But a good idea to maybe drop both, but want to continue at least Pembro.
Thank you. Fed?
Yeah, thank you for a great discussion. Fed Ghali from Yale. I want to take us back to this IO after IO question for a second. with the approval of EV-PEM and those data, has it changed your practice for using adjuvant nivolumab after cystectomy? And is there an argument to be made that maybe in the highest risk patients, if our pretest probability is so high that it's not helpful to give IO after IO, it could be the case that maybe the highest risk patients are the ones you want to withhold a checkpoint inhibitor for, so that you still have that card to play when they metastasize. To try, instead of trying to get that DFS benefit in the adjuvant setting, maybe you can get the OS benefit up front. What are your thoughts? What have you been doing?
I think that's a great point, and when I discuss with patients with the adjuvant, I do tell them that there's no OS benefit, but if things were to get worse, we have EV-Pembro. A lot of patients don't really want adjuvant therapy. Same for kidney cancer. Not everybody wants to get adjuvant Pembro.
Yeah, I think Fed is a great question, and I think we're all discussing this in a debate fashion, and we try to figure out the best. It's, of course, individualized discussion with the patient. My take is still, in my mind, adjuvant is still a curative intent scenario. So in my mind, I will still consider giving the adjuvant nivo. I would probably not withdraw it for now. I will still discuss it with the patient because there is a prospective, use of EV-Pembro metastatic disease, because metastatic is still palliative. We may start curing some patients, in a proportion of them, but I still think, there is some distinction in the mindset. I know Brian has a comment, I want to hear it. And the last comment I will say is, we don't know about overall survival in the adjuvant nivo trial. There was an interim, not final result at EAU in Paris in April that showed the trend towards overall survival benefit. We have to see how the data matures. Brian?
I think it's a fascinating question, right? And so I guess Petros would ask you or anybody, do you think adjuvant nivo cures patients who wouldn't otherwise be cured? And do you think EV-Pembro cures patients? Because to me, those are critical questions to answer that question.
I agree, it's fascinating indeed. I think there's probably a small fraction of patients that can be cured with
adjuvant
nivo. And similarly, there is probably a small proportion of patients that are cured potentially with EV-Pembro. The problem we have is still in the mindset, we have a curative intent setting in the adjuvant, and we're still trying to figure out whether we cure people with metastatic disease. So that's still what holds me back to withdraw adjuvant nivo.
I mean, and again, you all see more of this than I do, but my sense is that EV-Pembro is way more curative than adjuvant nivo, way more. And I've tried to get Tom and others on the podcast to say this, like, you are curing patients with advanced bladder cancer with EV-Pembro. There's no way your CR rate's 30% and you're not curing patients. Our CR rate's 10 to 15%, and we're curing probably 10 to 15% of patients. So I think it's like the bladder cancer community has to embrace it and say, yeah, you're actually curing patients in the metastatic setting. Like, let's all say it out loud. It's okay. I think so. And if you disagree, let me know. But I have the same concern for like resected M1 patients, giving them adjuvant Pembro. I think it's under treatment.
Right.
It's under treatment. Yes, it's an active drug in the metastatic setting, but it's not a standard of care. So I don't treat those patients with adjuvant
me neither.
Pembro.
But that data is getting extrapolated as, okay, somebody had a nephrectomy, then let's just do a metastatectomy and give adjuvant nivo.
Yeah,
Then
makes no
ideally they
sense.
should be getting ipi-nivo or TKI IO. So I think we have to be very careful. But I agree with Brian. We have patients 3.5 years out from EV-Pembro with CR, NED, and on no treatment. And maybe
That's
this is the
remission.
next ipi-nivo.
Yeah,
That's cured
yeah.
by definition. If you want to wait for 5 years, that's not.
And we see the tail of the curve indeed. There's probably 20 to 25% of patients with EV-Pembro that are in the tail of the curve. And I had this discussion with a patient last week. We think we're starting to cure patients with that context.
And so,
but I think it's a great discussion.
Just one last comment. I think that's kind of my sort of sense also, and I think that just like Pembro and kidney cancer, there's at least the potential that we're both way over treating the cured patients with adjuvant therapy, and then of course under treating because we're not giving doublet therapy in the first line, or some of those patients are really metastatic patients, and so they're being undertreated with single agent checkpoint inhibitor. So anyway, fascinating. Thank you.
It's a great discussion. Just to add briefly that there are ongoing perioperative trials with Pembro EV, Keynote 905, that Silpa you mentioned, the Keynote B15, that are asking the EV-Pembro question in the neoadjuvant adjuvant setting. So that may be a very hot topic coming up in the future if we move that regimen.
I'll just add one thing to those sandwich trials, that I think that's over-treatment too. For someone who has a PT0, why do we need to give them 9 more months of EV and Pembro?
Great discussion, and we'll see the Niagara data soon, and we'll discuss that as well. Amta.
Thanks, Petros. Thanks. This is a great discussion. And since we all have you here, I also have a bone to pick about adjuvant nivolumab. So I'm curious about what everyone does for upper tract urothelial carcinoma patients who don't get platinum in the neoadjuvant or cisplatin in the neoadjuvant setting, because I really have conflicted feelings about how to treat those patients. And like you mentioned, Shilpa, PD-L1 is no longer something that we can really hang our hats on there either. So I'm curious how people manage that decision.
I don't offer it to upper tract patients. I mean, I discuss it and say that it doesn't work.
Do you offer platinum instead?
But neoadjuvant? Yeah,
No,
when
adjuvant.
adjuvant, yes.
Yeah.
I use the POUT data
Yeah,
for that.
yeah.
Yeah, great discussion. We have this question about the biology of upper tract versus bladder. I think the data with adjuvant IO in upper tract is very uncertain. Wide confidence intervals, high degree of uncertainty. Assis, and then Omar, and then we'll move on.
Great discussion. Enjoyed your talk, Shilpa, as always. A quick question, because we were talking about IO in the advanced setting, right? And then if you move it into the earlier setting, patients who have muscle-invasive disease and metastatic disease after BCG therapy in the bladder clearly have a worse prognosis. And I don't know if Pat Hensley's here, but he showed very clearly that's a huge negative prognostic factor. We're also seeing patients now that get Pembro after BCG and develop metastatic disease on Pembro, and patients who develop de novo metastatic bladder cancer while on Pembro for other diseases. How does that think or alter your thinking about whether to offer EV Pembro or what you would bring in those patients who have developed metastatic disease or invasive disease while on IO therapy?
I would not offer EV Pembro to them. Would offer platinums or single agent EV if they've already demonstrated that IO did not work.
And then how does that change your thinking with patients, what Fred talked about, patients who are on Nivo and then progress? Would you still come in with an IO EV, like EV Pembro, or
No.
would that also change your thinking in that setting?
It will change my thinking
And
to skip the IO.
Petros, you so often hinted that you would do something different.
You know, I think it's very, very difficult, again, the absence of cancer-specific data, but if someone has progression while on IO, in my mind, this patient has a very low chance to respond to any challenge of IO. So I would switch to different treatment. So the question, if that patient, for example, goes from NMIBC on Pembro to metastatic, which is rare but can happen to your point, I will use a different approach to the platinum-based chemotherapy, or if I'm platinum ineligible patient, so I would not continue or challenge with IO if someone is progressing while on IO. And some people may have different feelings about the time interval, right? The treatment-free interval. Did you progress 3, 6, 9, 12 months? People may have a different, approach. And Brian already said that he wouldn't probably do it in kidney cancer, right? To re-challenge with IO. I think people do it, and that's maybe the other reason to do the trial, to impact the practice. But if someone's progressing while IO, I feel less enthusiastic to use it again. That was your question, Assis, right? Yeah. And great work you're doing in the field. Omar?
Yes, thank you for the very vibrant discussion. I think I just want to echo. It frustrates me sometimes when I see patients in the clinic and they are progressing on adjuvant immunotherapy. They had neoadjuvant cisplatin and they are on adjuvant nivolumab because they have a bad biology. Unfortunately, they didn't respond to neoadjuvant therapy. They come with node-positive disease. We give them adjuvant nivolumab, and then, I offer them third-line EV because in my mind, this is third-line therapy. Their disease already failed neoadjuvant cisplatin, didn't respond to it, and it's progressing on adjuvant nivolumab. I think we always have to remind ourselves that EV302 excluded these patients. Like you could not have had prior IO, and the frustrating part is when they go to someone and they quote the 70% response rate to EV Pembro. And the patient comes and read the news, why aren't you giving me that? So I think as a community, we have to stand to the criteria, the inclusion criteria that we do for these trials, and remind ourselves when we're seeing patients that don't fulfill those inclusion criteria that the data cannot be extrapolated. And I don't think we need another trial, to be honest. If we wanted to answer that question, we should have changed our inclusion criteria from the get-go for those big trials, but we're obviously trying to pick for winners. Same thing and I want to highlight what Shilpa mentioned in the perioperative studies with EV Pembro. It's similar to chemo. When we give neoadjuvant cisplatin, if you respond, EV is chemo at the end of the day. We don't give adjuvant cisplatin. Or if you didn't respond, we don't give you cisplatin. So in both, you're kind of damned if you do, damned if you don't. So if you achieve a PCR after EV pembro, I don't think giving you continuous EV pembro will make sense. And if you didn't, well, that is the regimen that didn't work, and you have node-positive disease. Maybe you should consider adjuvant cisplatin if you're a candidate. So I'm just thinking, once these trials become mainstream practice, are we going to follow the paradigm that was designed in these trials or not?
These are great points, Omar, and I can tell you there's going to be a very interesting discussion about Niagara trial coming up in a future meeting, and those questions about the adjuvant component will come up, and I think it will be great. I'm sure Euromigos meeting will dissect the data as well. Great points, Omar. And back to Mamta's question, because of this wide confidence interval, it's a great question, Mamta. We struggle, when we have these discussions with the patients. It goes back, could we do a dedicated upper track trial with adjuvant IO? I doubt it. That's feasible to do, and resources-wise. And it's interesting, we're going to see more data from the ambassador trial in the upper track subsets, and this data will be broken down, Mamta, to kidney, pelvis, and ureter, so we'll see some data. Last quick shout out, I see Karine and Ali there. We have a working group, actually, with the two of you and Dr. Chablani and Dr. O'Donnell, trying to answer practically what people do, what's the behavior in terms of reusing IO in real practice, and if they want to re-challenge, what's the time point of the treatment-free interval. If they re-challenge, they do it after someone's progressing 12 months or 9 months or 6 months after. The answer, Brian would probably say, I would not reuse it, but if people do it, what is the time frame? So we're working on that survey. Ali, I want to make a quick, very, very quick comment, though.
And if you have not received the survey and would like to, let us know. We'd love to send it to you.
Yes, that's a good plug. Okay, Neelam.
Petros, I have a very quick question, and this may be naive because I'm mostly focused on the non-muscle invasive space. Are there any differences between patients who have progressed from NMIBC following BCG and those that have de novo MIBC in response to these?
Great question. Actually, we did a retrospective study. Madhuri, great question. And I think Dr. Talukder is in the audience, who was our fellow at UW for HATS, and together with our team, we did a retrospective study, and we look at response to checkpoint inhibition for systemic metastatic disease, advanced disease, in patients with or without prior BCG exposure. We did not see any major difference in that regard. Obviously, the challenge is how much data you can capture granularly in a historical fashion retrospectively. So with that limitation caveat, I don't know if Rafi, you're here, you want to comment, but we didn't see, and Ali, you're part of it. I don't know if you want to briefly comment on it, but we didn't see any major difference, right? Perfect. So retrospective study, but we tried. And the subset analysis in the big trials, again, it's challenged because it's hard to go back and collect that data. Neelam, you're on.
Yeah, this question for Shilpa. If a patient fails EV, do you think there is still space to look at Nectin-4 and do other Nectin-4 targeted therapies? Like we heard a talk about the CAR. It was very interesting because I thought that it won't be a viable target anymore. So just wondering what your thoughts on that is.
So I'll rephrase since this is a patient advocate meeting. If EV fails a patient, then yes, I was also intrigued by the talk yesterday. It all depends on the payload and the linker. Mm-hmm. And there are a lot of new Nectin-4 targeting ADCs in development. So I think there will be room to do that, even combine it with EV if the toxicities are non-overlapping. So that's a great question.
Thank you.
Excellent discussion. What a great, amazing conversation. So Neelam and Madhuri, you take it on. Show us the science.
That was a great start. This very, very interesting discussion. Thank you, Shilpa, for covering all of that and answering all of the questions and starting the session off. So we are going to switch gear a little bit and go a little bit deep into the basic science aspect of the session. So I will talk today a little bit about the role of innate immunity in bladder cancer. So this is a very basic slide to talk about tumor-infiltrating lymphocytes. And most of the research till now, and when we talk about tumor-infiltrating lymphocytes, has been focused on T cells, and especially CD8 positive effector TILs, and a number of studies has found them to be associated with improved survival, and vast majority of the studies has been focused on T cell targeted therapies, and though it's a very exciting time to do immune therapy studies, still a substantial portion of the patients shows partial or no response. And many of the tumors and a number of studies have found that many tumors downregulate class 1 MHC as a mechanism to evade from T cell cytotoxicity. And this is what make NK cells very intriguing, because in such a setting, they don't need MHC1 expression, and their activity is actually increased in absence of MHC1. So to talk a little bit more about NK cells. So these cells were discovered really in the 1970s, and what was unique about them that it didn't need prior antigen sensitization to carry out their function. So the way the mechanism works, that when a normal cell is there, the inhibitory receptors bind to the inhibitory ligand on the NK cell and keeps their activity in check, and this is important because otherwise we'll get a lot of self-activity and autoimmunity issues. But when a cell is infected or say a tumor development, as I mentioned before, that they may downregulate their class 1 MHC to evade from T cells, but that in turn may make them more vulnerable to NK cell cytotoxicity. It's kind of neat mechanism and balance between the two sides of immunity. So other reasons why NK cells are also cool to look at is because they can target tumors because of the same reason with low mutational loads. They have other mechanisms in addition to direct cytotoxicity, such as antibody-dependent cell cytotoxicity, and they can also modulate the adaptive side of immunity by release of cytokines. Their activity has been shown against primary and metastatic tumors, and clinical studies have revealed efficacy, especially in hematological malignancies, and there is a slow but growing interest in solid tumors. And for adaptive transfer studies, the NK cell safety profile has even been better than T cells in the studies. And as I mentioned before, that they are tumor antigen agnostic, so they're effective against a wide array of tumor cells. So when I started working on NK cells, at that time there was two subsets of NK cells known, and CD56 dim subset, as John talked about before, was thought to be this immature precursor of CD56 bright, and they had higher cytotoxicity, higher cytokine release, whereas the CD56 bright is kind of this immature NK cells that had lower cytotoxicity and but can release some of the cytokines. So that was the landscape known when we started the project. But interestingly, what we found in the bladder is that there is not only higher level of interferon gamma production in the CD56 bright subset, but their cytotoxicity was also higher compared to CD56 dim. So this was kind of surprising for us because it was going against the dogma that was in the field at the time. So we dig a little deeper into characterizing the CD56 bright NK cells and found that they are actually more activated, had higher expression of NKp46, NKp30, NKG2D, and also had higher expression of interferon gamma, perforin, and granzyme, the kind of the downstream molecules that mediate NK cell cytotoxicity, validating that this bright subset seems to be different from what we see in the circulating form of the CD56 bright cells. So next we wanted to ask the question of what impact the cells have on the survival in bladder cancer patients. And we found that the CD56 bright subset actually correlated with improves both overall and cancer-specific survival, whereas the CD56 dim subset, which was thought to be the activated subset, didn't. And right around this time, a number of studies in other solid tumors also came out talking about how this bright subset was different from the CD56 bright subset that we see in the periphery. So, and this is a lingering question that remains in the field, and I think John gave a brilliant talk before about how the tumor-resident CD56 bright NK cells differ from the circulating CD56 bright NK cells, and they may be actually developmentally distinct as that was previously thought. We also found that the CD56 dim subset surprisingly seemed to be increased in the higher stage of bladder tumors, suggesting that the dim subset seems to be dysfunctional in the bladder tumor microenvironment compared to the bright subset, even though there is a significant percentage of them in the microenvironment. So next question that we asked, that since CD56 bright NK cells was correlating with improved survival and they were functionally more active, so for decades we have known CD56 as this canonical NK cell marker, but their function is not exactly understood of how they participate in NK cell mediated cytotoxicity. So to answer this question, we knocked out CD56 in NK cells and then investigated what happens to the functional activity of NK cells. And we found that deletion of CD56 significantly decreased the bladder cancer cell death and also decreased interferon gamma and granzyme B production in NK cells. We also found that cleaved caspase-3, which denotes the NK cell mediated apoptotic cell death, also was decreased significantly in the CD56 knockout cells. We also carried out a confocal microscopy to get a visual representation of what is happening in the interaction between NK cells and the tumor cells. So you can see the round circles, the smaller cells, where the NK cells and the flat or the bladder cancer cells, and you can see the nice immune conjugate formation between the two cells in the wild type, and then the condensation of perforin at that conjunction where the NK cells touches the bladder tumor cells. However, when we look at the CD56 knockout cell, even though there is some immune conjugate formation, the perforin there is much more diffuse, suggesting that the downstream activity of NK cell cytotoxicity is kind of affected when we delete CD56. We also looked at the NK cell adhesion between to the tumor cells, and this was kind of a logical progression because NK cells are NK cell CD56 was initially discovered as an adhesion molecule in neural cells. So it was not surprising to us that it affected the adhesion between tumor cells and NK cells. We use atomic force microscopy to investigate this, and as you can see with the knockout of CD56, the adhesion between the two cells is significantly decreased. We also found that the NK cell migration towards the bladder tumor cells was also affected by CD56 deletion. And finally, we carried out this spheroid disruption assay. So basically, we created this 3D tumor spheroids from bladder cancer cell lines and then co-incubated with both wild type and CD56 knockout NK cells. So with the wild type, you can see that the margins are kind of all over the place. They are disrupted, whereas when the CD56 is deleted, we can see this clean, defined boundaries in the spheroids, and where the NK cells is failing to invade into the spheroids and disrupt them, suggesting that CD56 has a much more direct role in NK cell cytotoxicity than that was previously thought. So the next question we asked, okay, so CD56 is doing all this downstream activities, but how? So one of the members that attracted our attention was the proline-rich kinase PIK2. So this is a member of the FAC family, and it's a non-receptor tyrosine kinase. And previously, it was shown again in neuronal cells, because that's a bunch of work has been done with CD56 in neuronal cells. It's bind to SRC kinase and kind of mediate the downstream integrin signaling complexes to promote migration and the adhesion in between cells. So PIK2 has also been shown to be critical in NK cells attachment to target cancer cells and release cytotoxic granules. Especially in non-immune cells, it has mediated and promoted exocytosis through interactions with the FAC family. So we collaborated with Dr. Emily May, so she is an NK cell biologist in Columbia, to help us delineate whether the axis that we see in CD56 mediated and intratumoral NK cells in the bladder is working in the same way. So for that, we used a PIK2 inhibitor, so it basically prevented the downstream PIK2 phosphorylation and blocked out the axis that leads to the PIK2-mediated cytotoxicity. And once we did that, we saw that in the wild type, the use of PIK2 inhibitor significantly decreased the bladder cancer cell death as well as MFI and the granzyme B production, but in the CD56 knockout cells, the use of PIK2 inhibitor didn't have an impact, suggesting that the CD56, at least partly, may be regulated through the PIK2 axis that modulates NK cell cytotoxicity. So the confocal on the bottom right, we were also trying to see whether this phosphorylation of PIK2 co-localizes with CD56 at the immune conjugate. And this is not a very pretty picture. We kind of disappointed when we did the confocal, but one interesting point that came out of that confocal, very surprisingly, we found that CD56 was also expressed by these bladder cancer cells. And even though it has been known for decades that this is the way we identify NK cells. So the next question we asked is bladder cancer cells really expressing CD56? And we had our cohort of bladder tumor patient samples, and we found indeed that there is a percentage of patients that express CD56. And we further validated it in the 3 cell lines that we had in our lab, the T24, UMUC3, and UMUC14. And we found that T24 had the highest expression of CD56, followed by UMUC3 and 14. And what was more interesting is that we found that the level of sensitivity to NK cell-mediated killing of these tumor cells actually correlated with their CD56 expression, suggesting that the CD56 on tumor cells may modulate NK cell sensitivity by a homotypic interactions. So to confirm that, we knocked down CD56 in the T24 cell line, which had the highest expression of CD56, and found that it significantly brought down the cleaved caspase 3 as well as the bladder cancer cell death that was mediated by the NK cells, suggesting that if we are going to target the NK cell axis, this may be a way to predict which tumor cells will respond to the NK cell targeted therapies. So one of the questions which the last talk also brought about is that we still don't know this, what is so unique about this tumor resident NK cells that is in the bladder tumor environment, especially when we found this unique population of CD56 bright subset that seems to be developmentally distinct from the CD56 dim subset. It's not a singular axis. So in this model, and we modified it from Dr. Vivier's paper, is that there are 2 hypotheses that exist. Is that one says that this CD56 bright cells or the dim cells may be recruited from the conventional NK cells that are in the bladder, and then they're differentiating into this unique version of highly cytotoxic CD56 bright cells. Another version is that these are completely developmentally distinct. They reside in the tumor microenvironment, and after being exposed to and this even in the normal bladder, and when a cell gets infected or a tumor develops, they differentiate it into the cytotoxic version. So that is a question that still needs to be answered. We found that the CD56 dim NK cells, the one with low CD56 expression, are also dysfunctional. So one of the ways is, there is a lot of studies, in at least the preliminary studies, that are investigating the adaptive transfer of NK cells, like cytokine activated adaptive transfer of NK cells. And I think right now, what it seems that we have the CD56 dim NK cells there. There's a predominant percentage of the tumor-infiltrating lymphocytes. So instead of adding more NK cells, I think we should focus on therapies that can activate the subset that are already there. But that's my 2 cents, and we can discuss more about it. We also found this unique axis that one of the basic questions to answer is that the CD56 may directly mediate NK cell cytotoxicity through the PIK2 mediated axis. And also one of the interesting points from the prognosis came up that tumor CD56 may actually predict NK cell sensitivity in bladder cancer. So from the therapeutic aspect, we have a number of ongoing translational projects in which I can't talk about the NK cell engagers we're developing. It's still with the OTC office, and they'll be mad if I disclose it here. But as I was mentioning, that the NK cell targeted therapies may be focused on activating the NK cells that are already in the tumor microenvironment. We are also investigating low-dose chemotherapy to modulate NK cell functionality, and also modified cytokines to induce NK cell cytotoxicity, and that was done being in collaboration with Dr. Aaron Ring from Fred Hutch and Simca Therapeutics. And also whether, and keep in mind that some of the regulatory molecules that we talk about on T cells and modulate their activity to ICIs are also expressed equally to on NK cells. So I think we are missing a critical subset of immune cells when we talk about immune checkpoint blockers and kind of ignore NK cells, because they also can be regulated by the ICIs as much as T cells. So if the big picture, and me and Petros also talked about it in our last session, and he was also doing a trial which was presented last year in ASCO about lirilumab and combining it with anti-PD-1, that we should not keep the innate and the adaptive immunity, the body doesn't, into separate boxes. I think we should develop synergistic therapies that target both innate and adaptive immunity, and at least start the conversation when we go out and try to develop novel therapeutics for the next generation of immune therapeutic strategies. And with that, I would like to thank all my lab members. Of course, none of this work would be possible without them. Anika, she's here, she did a bunch of the work. And also Zaneb, my grad student, did majority of this project, which I showed you today. And of course, all my collaborators and funding sources. So thank you for your time, and I can take any questions. Thank you.
As always, and it reminds me that we need to talk more about the biospecimens from our trial. It was just published a few months ago with neoadjuvant nivolumab plus lirilumab and modulator of the NK cells, a KIR inhibitor. So very exciting work. Any questions? I see Jason on the microphone.
Yeah, so that was a really interesting talk. So one of the things I'm interested that you talked about was, PIK2 kind of being necessary for the CD56 mediate inhibition. And one of the downstream elements of PIK2 is PI3 kinase, something that we see frequently mutated in bladder cancers. So do we see differences in terms of the innate immunity in these PI3 kinase mutated tumors?
Yeah, and that's a very relevant question. We have not done that work, but that's in our roster to look at the more downstream signaling. And as I've mentioned, now, since we are also seeing that the tumor CD56 is also playing a role, so how that interaction affects the homotypic interaction and the downstream signaling complex, and which specific signaling is getting affected. And yeah, it might well be that there is a difference in cytotoxicity between the PI3K mutant tumors, and that again may decide, we are moving more towards personalized and precision medicine of which subset of patients can be a good fit if we go through the NK cell targeted therapies. Yeah. Thank you.
Thank you. Very interesting work. Interested to know your thoughts on, or have you done any work with ULBPs, the sort of the ligands for NKG2D, and what you've seen or learned about that?
Yeah, we have done some work with NKG2D, especially because when we started off the project, there was a bunch of papers came out about the shedding of those ligands and how that can inhibit the axis. So from the same setting, we actually looked at CD56 shedding and see whether that can be a method of I didn't show that data today, but Annika also did that part of the project. And we found that when there is this CD56 shedding, we see a more of an NK cell exhaustive phenotype. And similar to some of the ligands, they may have an inhibitory impact on that axis. And then again, we did that in both patient urines and comparing it between the healthy subjects and bladder cancer patients, and see whether that can predict again to the same question of which kind of therapies they can respond to. But it's a very interesting question. Thank you for that.
Thank you.
So we're now going to learn much about bladder cancer from leaders who are treating other malignancies. Dr. Bladder will run through the cutaneous malignancies, and then Brian about kidney cancer. Shalender.
Well, thank you, Petros and Neelam, for organizing this fantastic session and giving me an opportunity. And if I can have my slides, please. And I'm going to set an 8-minute timer because we want to leave enough time for Dr. Rini. All right, so what is a skin cancer guy doing here in this bladder cancer meeting? I'm actually asking myself that question too. But just hearing all the fascinating discussion this morning, I actually feel like I'm here to brag. All that you guys are talking about, we have been there, done that already. So I'm happy to share some of those experiences here. So these are my disclosures. So why care about skin cancers? They are actually the most common cancer in US, but they're also an excellent model for cancer immunotherapy. These are thought to be highly immunogenic. We know that PD-1, PD-L1 blockade works around approximately in 50% of the patients. And if you see this figure here, the response to PD-1 is shown, and then the different cancers are shown. Everything on the high side, all of the red bars are different kinds of skin cancers. So it's fascinating to see that at least among solid tumors. And then also skin cancers, just by virtue of their locations, we can do serial biopsies. We can learn a lot about those tumor immune interactions, which can guide our management in the clinic. And the big advance in immunotherapy in stage 4 melanoma, you can see the impact of that. I was asking Petros how the survival in bladder cancer has changed, and he's told me something about 16 to 32 months or something like that. But as a comparison here, you can see the historical overall survival in melanoma was 8 months. And now you see the impact of immunotherapy. It's 72 months in the IPI-NIVO trial. So we have had a big, big improvement. And so I've been fortunate to be part of this journey, and as part of this journey, I've kind of taken home several lessons, mostly based on my interactions with individual patients where we are trying to chase these immune responses. So the lesson number 1 is that we have to know thy enemy. Understanding disease biology is the key to success, and I will use Merkel cell, which is a special interest of mine, as an example of that. So this is a patient who lived in Chicago and came to see us in Seattle. And you can see he had diffuse involvement of the scalp with these tumor cells. So he had very advanced kind of Merkel cell, but mostly located on the scalp. And he was 81 years old. And despite being that age, he actually was very energetic, almost as energetic as Dr. Grivas, not quite, but similarly nice as Dr. Grivas. And it turns out, he had this multifocal involvement, was all Merkel cell, proven by different biopsies. So this is what the state of affairs in Merkel cell was at the time when we saw him. People had looked at multiple pathways, but there was nothing that actually worked out. The whole field changed when in 2008 we learned that there is a virus that can cause Merkel cell, and it's the Merkel cell polyoma virus. And soon after, we learned that there is a significant role of of immune cells in the pathobiology of Merkel cell. PD-1, PD-L1 interactions were there, the T cells were exhausted, and that led to this fascinating revolution in Merkel cell with different PD-1, PD-L1 antibodies. I'm not going to go into detail of the data, but you can see all of these are FDA approved for other cancers, and 3 of them are at least approved for Merkel cell. So lesson number 1 is we need to know the biology, and then we can have significant progress. But the lesson number 2 is when we are writing a manuscript, we should never write the conclusion before we actually see the results. And why do I say that? So when we did all those initial trials, we thought that those drugs are going to work in those patients who have the virus. But virus-negative Merkel cell is not going to respond. And virus, fortunately, was present in 80% of the patient's tumors. So we thought, well, and also at that time, we wanted to do those trials in virus-positive patients, but we did not have a good clinically validated assay to actually look at the viral status. So we said, well, 80% is good enough. We will just treat everybody regardless of the viral status, and that's how those trials were done. But to our most pleasant surprise, you can see here, people who were virus positive obviously responded, but virus negative patients also had very high responses. And that was an utter surprise at that time. And one example of a virus negative patient with huge liver metastases is seen. This person got avelumab, and it worked beautifully. And this person is still in remission, like almost now 10 years out. So fascinating biology was at play, and we did not quite understand it at that time. But that led to further studies trying to understand the biology of virus positive and virus negative. And tumor mutational burden was getting very popular at that time. And it turned out that virus positive Merkel cell on the left-hand side had the lowest tumor mutational burden of all tumors. And virus negative Merkel cell on the right-hand side here of the spectrum had the highest tumor mutational burden. So then again, there was another surprise. So that has panned out in other viral malignancies as well, that despite low tumor mutational burden, we can see very high responses to ICI. So lesson number 3 is choose quality over quantity. For effective immunotherapy responses, we only need a few good antigens, and tumor mutational burden can certainly help us enrich that patient population towards more quality antigens, and we call those neoantigens and so on. So going back to the case, so we had the pembrolizumab trial ongoing at that time, and he was actually patient number 1 on the pembrolizumab trial, which was subsequently published in New England Journal. And unfortunately, he was a spectacular non-responder. Pembrolizumab failed him. And so then we kept going, but you can see now his tumors started becoming a big problem. Every time he would sleep, these would bleed. And so that's when we used palliative neutron radiation therapy. He had already had conventional radiotherapy to the scalp, and we are the only center which is commissioned to actually do neutrons, the heavy energy particles. And he had a spectacular response to neutrons, which kind of got him to another few months without cancer, but the cancer still came back at the edge of the radiation fields. So now we had a clinical trial. We have been talking about NK cells all day long. So we had a clinical trial of activated NK cells, and we used that trial in him, and it actually started working right away in those tumors. And it took a slow process of 4 months for that whole thing to evolve, but you can see the benefit happening. Now, after 4 or 5 months, he was coming from Chicago every 2 weeks or so. There was something residual, and we biopsied it, and there was Merkel cell still present. So then we said, well, maybe something dramatic is happening here. Let's try reintroducing pembrolizumab. We have been talking about IO after IO earlier this morning. This is, again, pembrolizumab did not work the first time, but now we used it again, and he had a spectacular complete response. And you can see August 20, okay, my 8 minutes are up. So now pembrolizumab worked really well when it had not worked. So I had a 2-minute question, so I'm going to use that now. So he actually had, he was, I think, what I would call a cure, durable complete remission, died from non-MCC causes. And a patient like this actually has guided my clinical philosophy. So the lesson number 4 is persistence is essential to the quest for a successful anti-cancer immune response. He took 5 immunotherapy interventions. None were FDA approved for MCC at the time. 3 were clinical trials. And the most important critical part in between was the debulking treatment. And in bladder cancer, you have several good options like enfortumab and so on. But how do you use those options? And this is what I would propose. This is my take-home message to you, that you need to chase those immune responses in every single patient. Your plan should be immunotherapy, immunotherapy, immunotherapy. It should not be ICI, 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 but immunotherapy of some kind, unless you are forced to use something else. And then, too, you need to use that modality as a bridge to the next immunotherapy intervention. So, and this is my last slide. Basically, what we need to do is this. This is a Hindu mythology. Ravan, the demon here, has multiple heads and kind of epitomizes cancer. You cut one head off, the head grows back. So what it took was identify a vulnerability in his armor, which was the umbilicus. If you throw an arrow at the umbilicus, that is what it takes to put him down. And that is, I guess, what we need to find out for cancer. We need to find that unique vulnerability in each patient, and we need to chase it relentlessly. So thank you.
While Brian goes to the stage, can I ask you a quick question? This was such a beautiful talk. You said the Pembro didn't work the first time, but you used that the second time. Was it because there was no other option, or were you hopeful that it might work the second time?
Is this working? Okay, great. So yeah, so what we learned from the NK cell trial, the time course that it took for that immune response to, so we chatted about innate and adaptive immunity. So what was happening with those NK cells, which are an innate intervention, 3-4 months after continued innate intervention, we probably led to adaptive immunity. So that was just a guess at that time. To harness that adaptive immunity, we reintroduced pembrolizumab, and that did the trick for the long term.
Amazing. Yeah, it's amazing.
That's very, very interesting. And I love the mythology slide at the end. The question is the predictive biomarkers. Brian can help us with that quest of predictive biomarkers for kidney cancer.
Good to be here. Thanks for saving me some time. I appreciate it. And I think, honestly, we need to do more learning across diseases, not just within GU, but across oncology. It's something we don't do more. So in my few minutes, I'm going to talk about kidney cancer data and how it can inform bladder cancer. We talked about this a little bit. Basically, when you get more and more active drugs in a disease, you can have effect on primary tumors. You obviously have effect on metastatic tumors. And I think this has really fundamentally altered the way we treat kidney cancer, and I think it's the same is going to happen in bladder. This is a table from a series from Vanderbilt, one of my fellows is putting together, that looks at patients who walked in the door with metastatic disease, usually primary in place. They got effective immune-based therapy. They had such a great response that we took them to surgery. There's a number of these series out there now. The details on the slide aren't important, but it's really just to say that there are multiple routes to cure for a patient. Thinking about consolidative therapy, be it after EV-Pembro or IO-based therapy in kidney cancer, is super important. And I think we're going to increase the fraction of cures by a immune-based systemic therapy plus some sort of consolidative therapy. In kidney cancer, it's easier. You have 2 kidneys, only 1 bladder, so you can send patients to nephrectomy and not really worry about it. A different story in bladder cancer, but I think the paradigm is the same. Adjuvant immune therapy this is the Pembro data in kidney cancer. These are the DFS curves. There's also OS, which I think I may show on the next slide. And although it improves DFS in both diseases and OS in kidney cancer, as we alluded to before, patient selection is very imprecise, right? We don't have ctDNA really in kidney cancer. We have maybe other tools I'll talk about. And as we talked about, maybe some patients to get better, to wait and get better therapy at relapse, right? We're by definition, over-treating patients in the adjuvant setting, and we might be under-treating others, and I think that's a fascinating discussion. And again, these are just the overall survival curve. So it is a bit of a different conversation in kidney cancer where we have definitive survival data. Having said that, if you look at the 4-year mark, that difference is 5%, right? So yes, there's a survival benefit. It's 5%. I don't think that's an overwhelming survival benefit, so I'm perfectly happy to have patients not receive adjuvant therapy, even with this OS benefit, and we can have that discussion. These are data that Laurence Aubiger has presented at ASCO that I'm biased because I was part of this, but I thought it was the best data presented for kidney cancer anyway at ASCO. So KIM-1 is kidney injury molecule 1. It's been around for decades, mostly in the interstitial nephritis world. Now in the cancer world, it's a biomarker that's both prognostic and predictive. These are data from the EMOTION trial of adjuvant atezolizumab. There's also data from the adjuvant ipi-nivo trial and the adjuvant TKI ASSURE trial from back in the day. And I put the ctDNA curves from a similar trial. And again, I think KIM-1 could be the ctDNA of kidney cancer, right? So it's a marker of residual disease. It's a prognostic indicator and also, again, seems to predict response to immunotherapy, at least in this trial and in the adjuvant ipi-nivo trial. These are all post hoc exploratory analyses, so take them for what they're worth, and we need to do more prospective work, but I think we will get to a day when we have a better biomarker-based selection of patients to favorably alter that benefit-risk ratio. These are just the predictive curves, and you can see they sort of flip in the KIM-1 high versus KIM-1 low subgroup. So another commonality across disease is that frontline single-agent immune therapy has activity, but unfortunately it doesn't hold disease for the majority of patients, right? And this was, I think, a painful lesson in bladder cancer, right? And I know back in the day when I was in Cleveland with Shilpa, and I don't know if you were there, Petros, at the time, but immune therapy had activity in bladder cancer, and so I was using it a lot, not quite realizing that it was under treatment for a lot of patients. These are kidney cancer data from single-agent trials. You can read the names there. And I put in the red box that primary progression rate up to 30%. So patients, maybe not quite to the degree that bladder cancer patients do, but because kidney cancer can be more indolent, but plenty of patients have biologically aggressive disease and really need upfront disease control. So single-agent IO, as I mentioned before, is not the standard of care in frontline of kidney cancer. I use it in patients who can't get TKI or are so frail, but you want to do something, but I don't use it much. What about triplets, right? And I don't know if this has been talked about here, but right, I mean, EV-Pembro standard of care, that's what I'm using in everybody. Can we build on it? Well, we've had this thought in kidney cancer. This is the COSMIC trial, was reported maybe a year ago. Ipi-Nivo plus minus Cabo, right? So taking the best of all the mechanisms that have activity in kidney cancer, PD-1, CTLA-4, and VEGF TKIs. It was a great idea. There was a marginal PFS advantage, no OS advantage, and it was really toxic. So if you look, this is data from Monty's discussion, and the columns on the right in each of these are basically saying that less patients were able to get all 4 doses of Ipi, which clearly is an active drug, and you can see 60% of patients required high-dose steroids. That's a lot. If there's a survival benefit, if there's a CR advantage, great, bring it on, but there wasn't. And so at least this initial attempt at triplets in kidney cancer was unsuccessful. There's other trials. Merck has a very large trial that's been accrued, and we should see in the next couple of years. So we'll see, but I don't know if this is a paradigm that would apply to bladder cancer. But clearly building on doublets can introduce toxicity. This is the IO after IO part of the talk. So this is our CONTACT-03 study. I think it's the most important negative study we've had in kidney cancer in a while, because I can tell you up until these data came out, I was seeing patients all the time who had Ipi-Nivo, then they had Axi-Pembro. They were getting sequential immune therapy based on anecdote and or single-arm phase 2 data. This is a summary slide, and what I've titled it is patients really only get one shot at immune therapy, at least PD-L, PD-1-based therapy. You don't have to be a statistician to see those curves are entirely overlapping. And disappointingly, if you look at the CR rates, so if sequential immune therapy, even if it didn't lead to a survival benefit, if you could cure more patients or lead to durable response, that would be a potential benefit that was not seen here. And sequential immune therapy came at a cost of increased toxicity, including 3 treatment-related deaths. So to me, this definitively changed the landscape. We should not be giving sequential immune therapy until and unless there's prospective data to show that. There's another trial called Nivo that we alluded to, will be presented at ESMO. It was tivozanib plus Nivo versus tivozanib, also press release, negative trial. Again, in kidney cancer, it's a little bit different because we do have CTLA-4 as a mechanism. And would you give somebody Ipi-Nivo? I don't know. I might out of desperation, but again, I would not do it routinely. Another topic is de-escalation of therapy. I think it got brought up during the questions, and Shilpa talked about a trial. This is the TIDE-A study presented by our Italian friends at ESMO, I guess it was last year, where they gave patients sort of induction IO-TKI, and then at 36 weeks, they tried to stop the TKI in select patients, that were responding. They did show that most patients were free of progression 8 weeks from axitinib interruption. That's in the top right there. So this was a small pilot study. It was a very select patient population. There are other efforts going on. But to me, this parallels sort of the EV-Pembro story and how can we limit EV. I know I do in practice. I'm happy to drop day 8, et cetera. Whether we need to study it prospectively or can we just do it, I suppose that's a question for the group. It's hard to study prospectively. It's hard to definitively prove in a randomized trial. Nobody's ever going to do a non-inferiority large randomized trial of this, I don't think. So it's pilot studies, it's clinical experience, but I think it makes sense across diseases. All right, so what I told you are these top 7 lessons for bladder cancer. Again, I won't read them to you, but I think they're true across diseases. I think there are a lot of parallels, and thank you for your attention.
Amazing, concise, and very clear. Thanks, Brian. This is super, super helpful. We'll try to squeeze a couple of questions before we go. Anybody from the audience who wants to ask?
While we wait for audience to come to the mics, I have a question, Brian. That was such a beautiful talk. So in your, we've seen remarkable data with Ipi/Nivo 8 years out and IO-TKI, obviously. So if a patient were to ask, what are my best chances for long-term survival, are you going to say it's Ipi/Nivo because we have that long-term, or still IO-TKI because it is still, we've seen 5-year data from your study, Axi/Pembro, and or you're in the 50-50 Ipi/Nivo versus IO-TKI?
Didn't think we were going to get it. I thought this would be the one conference where I didn't have to talk about that. I think, Ipi/Nivo has the longest data, and it also really plays into its strengths of the most durable responses. If you took 100 patients and treated them with an IO-TKI, call it Len/Pembro or Ipi/Nivo, the number of durable responders is the same, right? Because to be a durable responder, you have to be a responder, right? And the response rate to Len/Pembro is 70 versus 40 for Ipi/Nivo. But there's no doubt that the quality of response to Ipi/Nivo is better, right? If you're a responder there's a better than not chance that you're probably cured of your disease or you're going to have long-term disease control. That's not as true for IO-TKI. So
I still see your patients 10 years out from Ipi/Nivo.
Yes.
CR.
I see.
Very quickly, we can go Fed and then Tyler before we wrap up.
Okay, thank you. Fantastic talks, all of you. One thing with the Keynote 564 data, as many have observed, there's been some a large chunk of patients in the control arm that didn't really receive what we would call standard of care, over 50%. And it seems to me that we have some of that happens in bladder cancer as well. The Nivo GemCis trial, even the EV302 has some of that. So I wonder if one of the lessons we can all be learning is there a role for standardizing subsequent therapy in clinical trials as a matter of policy or practice, and curious your thoughts on that.
Yeah, it's a good question. It's a complex one, and I think part of it is data collection. We do a terrible job of collecting what happens after patients progress on trial. We've all done trials and know that data collection is marginal at best. So in that trial also, over 20% got either surgery or radiation, so they may not have needed immune therapy. And there's good reasons not to get immune therapy. Like you have an isolated recurrence, you can get surgery. Those patients maybe don't need immune therapy. There are also bad reasons, i.e. you live in a country and you didn't have access, and we don't know from the data presented, and frankly probably will never know, what the exact reason was.
Yeah, it's worth noting that in the forest plot for overall survival, both for Keynote 564 and for EV302, the only group that really doesn't have a benefit in the forest plot is the US patients. It's kind of a common pattern, and it's not conclusive, but one wonders, is that partly because we're maybe more regimented here in the US in terms of delivering subsequent therapy? And anyway, just a thought.
A hypothesis, I agree.
Hypothesis, yeah.
Great discussion. Tyler.
Fantastic whole session. Really, really appreciate all your time. And the last 2 talks I thought were tremendous. I would say that I was impressed to see a slide that said immunotherapy, immunotherapy, immunotherapy as the conclusion of one. And then for the other one, where the 6th point or 5th point was you only get 1 shot at immunotherapy. So it felt, I felt like that was so appropriate because there are all of these lessons that we are trying to take from other diseases and trying to incorporate them into, right now we're talking about urothelial and bladder cancer. And it is hard because part of us, I think we want to push for more immunotherapies and a novel thing. And then there's the question of, well, maybe we just need to do all these immunotherapies at front, in the, front line. And I guess I would ask this as an opportunity to ask you, Brian, especially as EV and Pembro has become frontline therapy, how might you think about investigating novel IO therapies in this setting? Because it's hard. It's hard when you have objective response rate of 70% or 65% to know how much that extra is adding on. And just love to get your thoughts about it.
Yeah, I mean, that's the response rate for Len-Pembro too in RCC, right? So I think it's a mistake to investigate novel immune therapies in an immune refractory setting. I think you're not going to see activity of a potentially active drug, and there's examples, I think, in melanoma or maybe other diseases that I don't know as well. But it makes it really tricky because you have to have patients and providers and IRBs and stakeholders all agree that either we're going to do EV-Pembro plus or we're going to do EV plus a novel immune therapy in a frontline setting, right? And I don't think that's wrong. I think in the context of a consented, IRB-approved trial, that's okay to do. Because if you just tested in EVP refractory patients, you're going to miss a lot of active signals. But I think it's a good challenge, right? We have such active drugs that we want to give them to everybody, but then there's got to be room for drug development.
Yeah, okay, is it working?
Yeah.
Okay. I agree, but I also disagree. I think based on the data that we have, I think it makes sense as to what Brian is saying. But I have had a different mindset over the last 15, 20 years. I think what we need to do is, first of all, we should consider, yes, there are some tumors that are more responsive to the agents that we have, but we have to have a fundamental belief that all tumors are immunogenic if we can find the right kind of immunotherapy for that patient's tumor and how it is interacting with that patient's immune system. So if we think of the problem as a battle between the cancer cells and the immune system, then I think what we need to do is find the right kind of manipulation between those two components. Sometimes it means addressing the cancer cells. We need to, whatever, enfortumab is a good example. And then we need to give the immune system a helping hand, which could be immune checkpoint inhibitors, but there are so many other components to the immune system. There are innate cells, there are all these myelosuppressive cells in the tumor microenvironment. So even the most poorly immunogenic cancers can respond to the right kind of immunotherapy. And what I was trying to show by that case is the first 4 or 5 attempts did not work, but then the 6th one worked so beautifully. And the principle there is if you get the immune system stimulated the right way, it can do wonders for any patient. And that is what we need to chase for each one of our patients.
Just quick, melanoma docs have such a different way of looking at the world, right? I mean, it's just like, it's so immune responsive that you're right. Like, let's just keep trying things. I think it's different for different diseases. And I would absolutely say we should be developing novel immune therapy in other diseases. How to do it, exactly where to sequence it. The point of my slide was like right now in RCC, we don't have data. Doesn't mean we shouldn't try, but you should absolutely not be doing it in practice. Again, the CTLA-4 question's different, et cetera. So while there are parallels between diseases, there are also important differences, right?
Thanks, everybody. Great discussion.
Such a great discussion, and when you have fun, time flies. And I think it's really amazing to see wonderful interaction and intersection between basic, translational, and clinical research here. So I would like to thank my co-chair and partner in this, Neelam. Thank you so much for doing this. And of course, all the speakers, Madhuri, Silpa, Selender, and Brian. Thanks for being here. We are learning from you, so this was a great opportunity. Thanks, everybody, for your attention. Enjoy the last few hours of the Beacon think tank, and safe travels home.